All right. Hello, everybody. Welcome to this orientation to the Oregon Sustainable Healthcare Cost Growth Target Program. My name is Sarah Bartleman. I manage the program. I'm with the Oregon Health Authority Office of Health Policy, and I have several other cost growth target team members on the call today. But mostly you are going to be stuck hearing from me. So next slide, let's cover just some quick housekeeping. We are recording this session and we will post the recording and the slides on our website either later this afternoon or tomorrow. And so you'll be able to reference this back and we will make sure you all have the slide deck available. Good virtual meeting housekeeping. If you can rename yourself in Zoom to list your name and your organization, that really helps us know who's here and keep track of everything. We appreciate that. Please keep yourself on mute. If you are not asking a question, you are welcome to be on or off video for this, although it is nice to see some of you. So hello, thank you for being on video. You can drop questions in the chat at any time. I'm going to pause for questions throughout and also at the end. I know that we are going to provide a lot of content for you today, and I absolutely expect there will be questions. We will try to get through as many as we can. Questions that we don't answer today, we will respond to in an FAQ and put them up along with the slides and the recording. So please don't hesitate to ask those questions. In the chat is the easiest for us, but we will also pause. Okay, and next slide, please. Okay, so just a little bit of why we are holding this webinar and what we're hoping to cover today. We want to share a little bit of background information and context about Oregon's Cost Growth Target Program. Some of you may have been tracking this from over the last couple of years through legislation, through our implementation committee work. Others of you, this might be brand new. So we're going to start from the beginning and provide a little grounding in what this program is, why we have it, how it relates to provider organizations, why we reached out to all of you. What do we even mean when we say provider organizations, and what is this program all about? We also want to have you get a little bit more familiar with us and the whole team here, as well as provide some other opportunities for you to engage with our program and talk about what's coming up for next steps and what interaction will look like between us over the coming months. So that is the goal for today. And like I said, I'm going to talk a whole lot, and I recognize there's about to be a whole lot of information coming your way. So apologies in advance, and thank you for joining us. Okay. Next, agenda. Like I said, we'll start with why we have a cost growth target, how the cost growth target program works, which provider organizations are subject to the cost growth target program, how the cost growth target is measured, and next steps on staying engaged. So let's jump right in. Why have a cost growth target? Let's go ahead, 2 slides, please. So we know, many of you may have seen this graph before. This is from The Economist. US healthcare costs twice what it does in other countries, but life expectancy, we're spending more and more, and we are not seeing the same outcomes. This has been sort of a known talking point, a known fact of health economics and what's happening in the healthcare industry over the last several years. Next. Healthcare spending is, go back one. Healthcare costs are increasing and have been increasing over the last 50 years. So this is looking at household budgets and household spending. And so the green line here, healthcare spending is continuing to take up a larger and larger share of that household income. And it's right up there with housing and utilities as one of the leading expenditures that people have. Next. Looking at some national data from 2009 to 2014, Oregon's healthcare spending grew at one of the fastest rates in the country. We're up there at the 4th highest, up there with North Dakota, Vermont, and Alaska. This data is a little bit older. This is 2014. The US Census Bureau and CMS Office of the Actuary do not publish the state level comparison that often. 2014 is actually the last time they pushed this data out, but we know that we were well above the national average at that point. Looking at a little bit more current data on the next slide, If we look at 2019, personal spending on healthcare still was higher in Oregon than the US average. So this is a per person spending amount in Oregon compared to US. But not only is the dollar amount higher, it is still growing faster in Oregon than healthcare spending is growing in the country nationally. So between 2013 and 2019, healthcare spending was growing at 34% in Oregon compared to 27% nationally. Next. We know that the high cost of healthcare is impacting people in Oregon in many ways. We know that having high healthcare costs jeopardize financial stability for people. People have to choose between affording healthcare and affording other things, whether that's paying rent or food, filling a prescription. There are constant choices that people are being forced to make. If we look at the average annual cost of commercial health insurance premiums, both what the individual pays and what their employer pays, that average annual cost is approaching the cost of a new compact car. It's right up there around $20,000 annually. And that is a significant amount of money to ask people to pay. That's just looking at commercial, but we know that the impact of healthcare costs are affecting people in all parts of the state, all types of insurance coverage. And it's leading to negative outcomes, preventing people from accessing care. We know that there's a good portion of people in Oregon who report that they're delaying care because of costs. And we know that this burdens some communities more than others, which exacerbates the health and wealth inequities across the state. Our team put out a report a couple of weeks ago that looks at some of these impacts and provides a lot more detailed data. We'll share the link to that later, but if anyone wants to dig in more to some of those impacts, we have a whole report behind this slide. Having a healthcare cost growth target, the goal of that healthcare cost growth target is to support a sustainable rate of growth for healthcare spending. So we are recognizing that healthcare costs and spending are going to continue to grow, but we want that to grow at a rate that's a little bit more sustainable. We want it to be more in line with economic growth, with other cost pressures, with other cost trends. So it's not continuing to outpace things like wages and inflation. And having that target sets that as a goal. It's an aspirational goal. So I'm going to say target throughout this whole presentation. It is a target, not a cap. And what it is saying this is our budget. This is what we think is a reasonable rate of growth for healthcare spending in Oregon. Next. Having that healthcare cost growth target does a couple of things. So by setting that budget, by setting that target, we provide a common goal. This is something that we can come together and say, we all agree, we all understand that this is what we think healthcare costs should grow at. Not everybody might agree, but that at least that is the intent, that there is a common goal and everyone can talk to a common value. It's also sustainable. As I said, we don't want healthcare costs to continue to outpace wages, inflation, other economic indicators. We don't want healthcare costs to crowd out people being able to afford other things that they need. There's also big impacts on state budget and paying for healthcare versus paying for other necessary services. So we want to bring those costs to become a little bit more sustainable as part of that big picture. We know also that there are many things that affect healthcare costs. This is a very dynamic topic. It's very complicated. There are lots of different pieces and factors moving. But the cost growth target program, having a cost growth target, takes the approach of saying we are focused on total cost of care. We are looking at everything. We are looking at the highest level roll up possible. And that is what we are addressing. And having that total cost of care approach allows for flexibility underneath, so that those different drivers that might be different in one market than another, that might be different for one organization than another, that might be different in one part of the state than another, that those specific levers, that those specific cost drivers can be addressed in a flexible way, where we focus on bringing the overall cost of care and slowing that overall rate of growth across multiple drivers. You might have heard other talking points or seen other policy folks talk about squeezing the balloon. And that is exactly what we're trying to avoid by taking this total cost of care approach. We don't want to focus just on one piece of the puzzle and then have costs expand to make up the difference in another spot. And then finally, the cost growth target also provides transparency. And I'll talk more about this as we go, but there is a a big reporting and transparency component of this program so that we all understand what is happening with healthcare costs. How are we doing across markets, across payers, across provider organizations, and what are those key drivers? And they're going to change. The cost growth drivers in the pandemic are different than the cost growth drivers before the pandemic, will likely be different after the pandemic. And we want to understand how that is evolving. Okay, next. So Oregon is the fourth state to adopt a cost growth target. This started on the East Coast. New England, Massachusetts was the first state. Rhode Island, Connecticut, Delaware, Oregon all sort of came on as the next cohort. States that are following us include Washington, Nevada, New Jersey, and it's growing. This is a growing policy area, a growing topic that states are looking at to address healthcare costs. California's been considering a program, Minnesota, Vermont. So this is a shared topic, and we are working together with our colleagues and with payers and providers in other states that are also looking at this as an approach. Next. One question that we get is, why do we have a cost growth target? Does it work? What is the point? Is it going to work? And right now, Massachusetts is the state that has had a cost growth target program in place the longest. They're the furthest along this path, and their results are pretty good. And so after they set their target, their commercial cost growth rates have been consistently lower than national. Has Massachusetts met its target every year? No. There's all kinds of things that go on, and we'll talk more about what it means to meet or not meet the target a little bit later in this orientation. But what they have done is they've brought that trend down. They've slowed the rate of growth, and that's really what we're hoping to do in Oregon as well. Okay, let's go ahead and talk about how we got here in Oregon. 2 slides, please. So Oregon's been talking about cost growth and high healthcare costs for a number of years. Some of you may remember, some of you may have been involved in the 2017 Legislative Task Force. This was the Senate Bill 419 Task Force, and they were charged with looking at Maryland's hospital rate setting model and determining whether or not that was a model that made sense and should be recommended for Oregon. That task force ultimately said, no, we don't think the hospital rate setting approach is the right direction to go. We think that we should take a cost growth target approach similar to Massachusetts program, and that is a cost growth target that should apply to all payers and providers in the state. For some of those reasons that I talked about earlier, because it sets that common goal, because it allows flexibility in addressing different cost drivers with that total cost of care approach. It's not just looking at hospitals, it's not just looking at pharmacy, it allows that flexibility. So that recommendation from that legislative task force led to Senate Bill 889 in 2019, which established the cost growth target program. It authorized the program, and it stood up an implementation committee and charged the implementation committee with making recommendations for how the program would actually work. That committee sunset in December of 2021 after they finished and their initial phase of work and delivered their recommendations. Last year in 2021, we also had a second piece of legislation that was House Bill 2801, and that authorized accountability mechanisms for the program. And I'll talk more about what those are as well. So this program is now firmly legislatively established, and we have been working on implementation with the committee and mostly on the payer side to date. We were originally planning to engage with you all as providers much earlier and have held off on that because of the pandemic. And we are picking that up now this year and really moving into this next phase of implementation. We're also moving forward with a new advisory committee that was just appointed. And so that group will continue to provide oversight to this program. And we are also starting to move into some of that reporting and public hearing transparency body of work. So there's a lot that's been happening, and this has been happening for a couple of years. So again, I know some of you may have been tracking this already and are pretty familiar with this path. Others of you, this might be brand new and why is this the first time I'm hearing about it? But there has been a pretty long path to get here to launching the program. Next. So throughout that process, from the legislative task force through the different bills and the implementation committee, a lot of stakeholders have been involved in developing the program. This includes public comment, this includes participation on the advisory committee, participation on the legislative task force. This involves providing feedback at meetings, participating with staff and our technical groups. And we've heard from payers and hospitals and health systems, employers and purchasers, independent providers, consumer advocates, researchers, health economists, and legislators. So there has been some broad stakeholder involvement in this program, and we are looking forward to including you all in this next phase and continuing to strengthen the provider voice in this next phase of the program. Next. As I mentioned, the implementation committee was charged with setting recommendations in 6 work streams to guide the implementation of the program. There is a full recommendations report. We'll share the link with you all if anyone's curious. That report sort of gives the full context and a lot of the details behind some of the way the program is being implemented, and that caps off the implementation committee's body of work. But we do have these sort of six work streams for the program, including the target, data use strategy, which is all of our reporting and analytics, accountability, quality, and equity. We are one of the states that has really called out and a focus on quality and equity as a portion of this program. So we want to make sure that as we're focusing on costs and as we're focusing on slowing that growth rate, that we are not creating any negative impacts on people, whether that's intentional or unintentional. We don't want to achieve the cost growth target by cutting access or by sacrificing quality. So a really core component of the program is making sure that we're monitoring that. We also want to focus on taking action. So it's not enough to just have a target. A target provides that common goal, that common measuring point, but it's just a number. At the end of the day, it is just a number on a piece of paper. And unless organizations, payers, providers, stakeholders, the state are taking additional actions to help meet the cost growth target, the program will not be successful. So we have a body of work around that as well. Okay, so next, I'm going to provide just a couple of highlights from those recommendations. Again, there's a full document with a lot more detail than I'm going to go into, but a couple of key things that are really important for you to hear today. The implementation committee did set the cost growth target. It's been set for the next 10 years. So for the first 5 years, it's been set at 3.4%. And that's based on historical gross domestic product and historical median wage. So looking back at some trends that include a couple of different economic ups and downs. Then for the second 5 years, the target is set at 3.0%. That's tentative. There's an asterisk to that. The new advisory committee will be asked to reconsider whether or not that is still appropriate. When the cost growth target was set, that was pre-COVID, that was pre-inflation. We also know that healthcare inflation tends to lag general inflation. And so some of these economic indicators could look really different when we come back together and reassess whether or not dropping to that 3.0% target is appropriate for the second 5 years. But the target has been set for the first 5 years. One question that we get a lot is the 3.4% target for the first 5 years going to be revisited given COVID, given a number of other things, given what's happening with the economy? And the answer is no. The cost growth target is the target, and we are going to measure relative to the target. And I'll talk more about what that means if we meet it and if we don't meet it, and all of the essential off ramps that we have, because it's not really a pass fail. You don't meet the target, bad things happen. It's you don't meet the target, and we want to understand why. And there are many reasons why the state, a provider organization, a payer may not meet the target in a given year. And we'll talk more about that in a few minutes too. Next. So the cost growth target applies at 4 different levels. So we are going to be measuring and reporting at these 4 different levels. So we're going to be looking statewide, all across the state, all markets, everyone, everything included. We're going to be measuring at the market level, so Medicaid, Medicare, and commercial. We're going to be measuring at the insurer level, so looking at specific plans, whether that's Medicare Advantage plans, whether that's Medicaid coordinated care organizations, or commercial insurance plans. One place that gets a little tricky here is if we're talking about product versus plan. We are not talking about product. So for example, a commercial insurer might have 3 or 4 different HMO or PPO type products. We're not measuring the individual products, we're just measuring at that individual commercial insurer. And then finally, most relevant to you, we are measuring large provider organizations. And I will come back to what that means and how we're defining that in a second. But next cycle first. Next slide, please, Jody. Okay. And surrounding the slides have been lost. If you can bring those back up, thanks. Okay, we want to analyze and understand what those cost trends and what those cost drivers are in any given year. And can you go back one slide, please? Thank you. Every year, we will also report, so that includes publishing a performance report of performance relative to the target and all of those cost drivers. There's also some supplemental analysis that will be happening along the way to understand those cost growth drivers. There is also the intent to have a public hearing every year to share the results of that report and to understand and dig in a little bit deeper in that public forum and have an opportunity to have a conversation about what's been going on. And again, as I said, relative to that taking action work stream, it's really not just about measuring relative to the target, but it's about measuring and identifying opportunities and strategies to slow cost growth. Where are there opportunities to address those high cost drivers and those trends that are identified, and how can those be implemented? An implementation might involve the state agencies, it might involve the legislature and more policy work. It might be voluntary efforts that payers and providers are taking on internally. It might look like some combination or collaboration across. We're not sure yet, but that ultimately we want to be identifying those strategies and implementing those to affect cost growth overall. Next slide. Slightly more process focused. Every year, we will also be going through this process as part of that cycle. So the data for this program comes from the payers, and every year the payers submit data to our program, and we go through a data validation and analysis, first with the payers and then with you, the providers. That will involve reviewing the data, understanding, validating, checking that it's all correct, that we all agree with what we're finding, looking at those initial results, understanding those key factors driving costs, coming to what we're calling the accountability determination. Did an organization, did a payer, did a provider meet the target or not? For what reasons? And then leading out into public reporting and ongoing oversight. Next. So let's talk about some of the accountability pieces in a little bit more detail. So one thing that we want to make sure that we're doing is that this program is as fair as possible and that we are accounting for as many pieces of noise that we can. So one of the steps that the implementation committee recommended that we are implementing is that only entities, so only payers and provider organizations that exceed the cost growth target with statistical certainty might be held accountable. So the first thing we're going to be doing after that validation and analysis is applying some statistical tests to see whether or not we can definitively say, did this entity exceed the cost growth target in a given year? We expect that this will address some small number problems. We expect that this will address some high cost outliers that might cause cost growth to fluctuate significantly from year to year. So we want to make sure that this is just one of those first off ramps, that if we cannot say with statistical certainty that cost growth truly exceeded the target, then that's the end of the accountability determination. Sort of the process stops there for any organization, and then that would just be reported out. For entities where we do have statistical certainty that the cost growth target has been exceeded, then we have this determination of reasonableness. And the implementation committee identified a number of potential good reasons that cost growth might exceed the target in any given year. And we want to make sure that, again, there's an off-ramp for those. This is what I was saying earlier, that there's not a pass-fail and then automatically accountability kicks in, but that we take a closer look and understand those reasons and understand that many of those reasons may be not within a payer or provider's control. So on the next slide, I'm going to highlight some of those factors. This is not an exclusive list. There might be others. We expect that this list will continue to evolve over the next couple of years. We will also be working on codifying this list and the process in rulemaking next year. So this conversation will continue to develop. But some of those potential factors. So let's say the legislature mandates a new benefit that commercial insurers in Oregon have to cover. That is out of your control as the health system. That is a benefit change that has been mandated that will likely affect cost. If that is the reason that you exceeded the cost growth target, that's okay. That's a good reason. That's a reasonable reason, and no accountability mechanisms would apply. We know that there might also be changes in taxes or other administrative factors. There might be changes in federal or state law that affect an organization's or an entity's performance relative to the cost growth target. Those would also be good reasons. New drugs, new treatments might be entering the market. We like to look back. We like to is probably overstating, but looking back at when the new hepatitis C drugs entered the market 2015 and 2016, that caused some really dramatic cost growth. That is a new drug or treatment. That would be a good reason for exceeding the target. Again, we don't want to be hindering access or quality of care in any way. And so we don't want this program to create any perverse incentives for not offering those new drugs or treatments because anybody's worried about their cost growth. We also have a placeholder for acts of God, pulling in some insurance language there. So we did not anticipate COVID when we were putting this together. COVID is a good reason. We know that healthcare costs have dramatically changed in different ways. Utilization dropped in early 2020. Now it's back up. We know that healthcare workforce costs are up quite sharply. There are lots of things that are happening we want to be unpacking, and some of those are going to be really good reasons for an entity exceeding the cost growth target. And then finally, the implementation committee really called out sometimes entities might be making investments to improve population health or address health equity. And that's a really important part of the work. It's really aligned with Oregon's health system transformation. And we want to make sure that that's not disincentivized. And so if investments in this area is the reason a payer or a provider organization is exceeding the target, that would also not cause any accountability mechanisms to be applied. Okay, next. Accountability has 3 phases. So the first is the transparency and the public reporting, and that's sort of that base level where every year we will be reporting performance and the cost growth drivers. For entities that do exceed the cost growth target with statistical certainty and without a good reason, the next layer of accountability that applies is a performance improvement plan. And this is a process that we are starting to work on. We are starting to work on developing out what that looks like. We're basing this on some work that Massachusetts has done. We're starting to figure out the templates, what would be required for a performance improvement plan, what that whole process looks like. That's something that we will be continuing with our technical advisory group over the next couple of months, as well as in rulemaking next year. So very early days for performance improvement plans. And then third and finally, our escalating accountability mechanism for entities that exceed the cost growth target with statistical certainty without a good reason for any 3 out of 5 years. So we're going to be taking a rolling 5-year window. And for an entity that continues to exceed the cost growth target without that good reason, there would be a financial penalty applied. We don't have a lot more to say on that. Again, we're going to be working with the TAG and with the rulemaking process to develop out how that financial penalty is calculated, how all of that works over the next year or so. But let me go to the next slide and talk about the timeline. Slide, please. So we began in this year 0 collecting some baseline data, looking at cost growth between 2018 and 2020. And that is the data we're currently talking about. That's the data we're going to want to begin reviewing with you this summer. Our first year of cost growth target performance, where the cost growth target applies, is looking at cost growth between 2020 and 2021. The data for that performance period will be collected later this fall. payers and providers will be reported publicly when we report publicly, likely in early to mid 2023. But performance improvement plans and financial penalties don't apply in this next cycle. Performance improvement plans, the first time any entity would be put on a performance improvement plan is based on cost growth between 2021 and 2022. That data will be collected in fall of 2023, validated in fall, winter 2023, and likely reported and performance improvement plans assessed in 2024. So we still have a bit of a runway. This phased in implementation was something that the implementation committee felt really strongly about. We know that addressing cost growth is not something that everyone can just snap fingers and contracts change, especially thinking about provider payer contracting cycles, which might be on a 2 or 3 year rolling cycle, and it might take time to implement some changes. So accountability does have that has that phased in timeline. The first time that a financial penalty would apply would be based on cost growth between 2024 and 2025. That data will be collected in fall of 2026, reported in early 2027. That is the first time that we would look back at the 5 years and say, are there any entities that have exceeded the cost growth target with statistical certainty without good reason in 3 out of those 5 years? So again, a ways before the financial penalty kicks in. Okay. I'm seeing a couple questions in the chat that are going to be covered in the next section. Max and Eric have some questions about the target evolving and the conversations. Max and Eric, have I briefly spoken to that in talking about
yes,
the
you have.
definition of
Thank you.
reasonableness? Okay, cool. All right, let me keep going. I know I'm talking really fast, so bear with me for a few more slides of content, and then we will open up for a broader discussion. So probably one of the first questions you have is which provider organizations are subject to the cost growth target, i.e. why did I get your email and why am I on this webinar? So next slide. The statute from 2019, Senate Bill 889, says that the cost growth target should apply to all providers in the state. That is a really, really broad charge. And we spent some time with the implementation committee talking about how to operationalize that. And the implementation committee identified 2 criteria to define what provider organization means for the context of the cost growth target program. So the first criteria is provider organizations that can be accountable for total medical expenditures. And the second is provider organizations that have sufficient patient volume. Next. So let's talk about what TME means first. So provider organizations that could be held accountable for total medical expenditures are those that could, in theory, take on contracts where they're responsible for the total cost of care because they either include primary care providers who direct a patient's care and or they could influence where a patient receives care. It's pretty key to note here that we're not defining this as organizations that do have total cost of care contracts, because we know that that's not sort of evenly distributed across the state, but that could, in theory, take on these contracts. So you may or may not have total cost of care contracts. That's okay. You could, in theory, take those contracts on because of the inclusion of primary care providers and the possibility to influence where a patient receives care. Next. So when we then think about who those provider organizations are that could influence care, that could take on a total cost of care contract, we are now talking about health systems, hospitals that have primary care providers, whether that's a larger affiliation or as part of outpatient facilities, medical groups with primary care providers, a subset of specialists that provide care coordination or primary care-like services, ACOs, accountable care organizations, and IPAs. So I also want to point out that when we're talking about provider organizations for this program, we are trying to roll up to the highest level possible. So I'm going to pick on a couple of the big health systems in the state. So if we think about Providence or Legacy as a health system, we know that there are multiple facilities within that health system. There are multiple locations. We are not talking about each individual clinic or each individual location. We are talking about the organization rolled up statewide, all of their facilities, all of their patients, all of their providers. So Providence, the health system; Samaritan, the health system. So for those of you who are part of a health system or have multiple clinic affiliations or hospital outpatient organizations, we are talking about you as a whole rather than your individual component facilities, if that makes sense. We are absolutely not talking about individual providers, individual clinicians. We are not talking about small providers who have very small patient volume. And we are not talking about very small specialists who are not affiliated or not part of that larger health system. So for example, an independent cardiologist with a very small practice is not part of this. A larger cardiologist who's part of one of those larger health systems would be part of that, rolled up into the broader health system. You might notice that I've been really clunky in my language. I keep trying to say provider organization. We've been trying really hard to not say provider because that causes people to think that we're talking about individual clinicians, and we are not. And we really want to emphasize that we are not holding any individual clinicians or individual folks accountable in this program at all. We are not measuring at that individual level. We're not even measuring at the individual clinic level. We are measuring at the health system level. Okay, so now let's talk about sufficient volume. So again, we want to make sure that we're addressing small numbers because cost growth and high cost outliers can cause a lot of noise in that data. And we also want to make sure that we're focusing on sort of the highest volume practices or highest volume health systems because that's where we can have the most impact. Next slide, please. So the second criteria is which provider organizations have sufficient volume. And we are talking about provider organizations that have at least 10,000 unique attributed lives across all markets, or at least 5,000 lives in any one market specifically, Medicaid, Medicare, or commercial. The implementation committee talked about attributed lives. The data that we're using is in member months, so let's convert that to member months. So at least 120,000 member months across all markets. For the first couple of years of this program, we didn't actually have that initial data submission. We were still building all the foundational parts of the program. So we didn't know how many attributed lives there were and to which organizations. And so for a long time, we couldn't actually say which provider organizations we were talking about. But we have been working through that initial data submission, that 2018, 19, and 20 data that I talked about. And we have been working through the attribution to understand which provider organizations meet this threshold. Next slide. And we recently put together a list of about 50 provider organizations that meet these two criteria, both have that accountability for total medical expenditures and meet that member month threshold. So this is just a snapshot of the top organizations ranked by their 2020 member months. You can see the full list in the link on the slide. And this is the list that we used to identify you all to send that letter a couple of weeks ago and to invite you to this webinar. This is what we're working off of right now. This list, the provider organizations involved, might change in future years. So it might be that a practice or a health system shuts down or merges or affiliates with another and the landscape shifts a little bit. So this list is going to be dynamic. There might be some organizations that fall below the threshold in a future year, and there might be new organizations that are added in a future year as well. Okay, I'm going to pause there for a minute. Any questions about how we identified provider organizations and what that all means for you?
Hi, this is Eric Schultz from the Children's Clinic. And I do have a question about I guess I'm going to call them the bubble teams, those that are kind of near the 120,000 member months, and how that would work if you've got, a practice that goes up and in and then bounces out and then goes back in and then bounces out. How will OHA work with those?
So I think in terms of how we intend to work with a practice that might fall on or off the list or with a health system, a provider organization, we would identify them for inclusion in a given year based on that year's data submission. We will notify all provider organizations every year that you've been identified. Hopefully the list won't change dramatically, but I think you're right. There are some that are on the bubble, and we've been kicking around this idea of providing a right below the threshold list so that organizations that may be in that space of moving up and down would be aware and would continue to see the data and track, even if they weren't necessarily meeting the threshold for public reporting and accountability in any given year. They could still follow along as part of the program, be still reviewing the data, and be more prepared if they fall in or out in a given year. I think we're not sure yet how we want to handle that. We'd love to hear your feedback, especially if you're an organization that's a little bit lower on the list, and how you might like to engage with us on this. Because I think we don't want to say all organizations, you fall off once and then you're forever off the hook. I don't think that's in line with the legislative intent and the way the program implementation recommendations are structured. But I think we also want to make sure that it doesn't come as a surprise to you every year. Oh, nope, I'm in this year. What am I supposed to do about it? So there is that gray area, especially for those organizations that are maybe in the bubble, but only for one market. Maybe you only meet this because of your commercial member months. So yeah, I don't know that I have a definitive answer. I think we're thinking about it. We'd love your feedback on how you might want to engage if you are in the bubble.
Thank you, I appreciate it.
Kristen.
Thanks, Sarah. Can you just give a high level about how lives are actually attributed to different provider organizations, and then speak in a little bit more detail about how cost growth target requirements apply by market?
Yeah, thank you for that. I am actually going to go to the next section of slides that talk a little bit about how we're measuring and attributing. So perfect setup. Okay, well, let's go ahead a couple of slides, Drondi. So how are we measuring the cost growth target? Cost growth target data represents spending for over 90% of people in Oregon. We are focusing on people with commercial Medicaid or Medicare insurance. We are not looking at spending for people who are uninsured. We are looking at spending for people that live in Oregon. It includes care provided by any provider in Oregon, as well as out-of-state care for those Oregon residents. So if someone lives in Oregon, has Medicaid, Medicare, commercial insurance, all of their healthcare spending, whether it's provided by an in-state or an out-of-state provider, is rolled up and included in what we're measuring. We are not including out-of-state residents, people who live outside of Oregon, whether or not they receive care from an Oregon provider. So especially for those organizations that serve cross-border areas, metro area, Eastern Oregon, Southern Oregon, you might have patients from out of state who come see an Oregon provider. We are not including those lives or their associated spending. So it's not everything. There's also a little bit of spending that we are intending to include, but it'll be sort of add-on at that state highest level. And that's spending that happens for, say, healthcare services provided by the Department of Corrections, healthcare services provided by the Veterans Administration, as well as Indian Health Service and tribal health spending. So there's some other dollars that we're trying to capture to be as inclusive as possible, but those aren't necessarily being measured at the provider and payer level. Next. There are two different metrics that we're using in the cost growth target program, and they apply to the different levels. So at the statewide, the market level, and the insurer level, we are measuring total healthcare expenditures, or THCE. That includes all of the claims-based spending from an insurer to a provider. It includes all of the non-claims-based spending from an insurer to a provider. So that includes things like any VBP arrangements, any incentive payments, other capitation arrangements. We want all of those dollars. We also are including the net cost of private health insurance, or some of those admin costs at that insurer and higher levels. And we're including pharmacy rebates. When we're measuring at the provider organization level, we're measuring total medical expenditures. And so here we're focusing on capturing all of the dollars that flow from an insurer to a provider organization. So that's the claims-based spending and the non-claims-based spending. We are also measuring based on allowed amounts. not paid amounts. For the most part, there's a caveat, but we don't have to go into those details. And that's because we want to capture both what the insurer pays and the patient cost sharing. We recognize that allowed amounts are not necessarily what the provider takes in. So there's a tiny disconnect there that allowed amounts are the most inclusive way to look at both the patient cost sharing as well as the insurer paid amount. And on the next slide, I'm going to show a little bit of a complicated diagram to show both complicated and very rough how one way to look at how dollars flow through the health system. So on this triangle, there are 3 gray highlighted boxes. And those 3 gray highlighted boxes are what we are measuring as the total medical expenditures for provider organizations. So, and at that top right angle, we are measuring provider revenue and the dollars that are paid by the patients. So any patient cost sharing. We are including the payments that the insurance plans make to the providers, whether that is the claims-based or the non-claims-based payments, and whether that flows through a vendor or directly. There's a bunch of nuance about TPAs and how all the dollars flow. But essentially, we are trying to capture all of the dollars that come to providers. We are not measuring premiums. We are not measuring the rate of premium growth. We're not measuring that as it comes in. We're measuring the dollars that are moving in the health system. So again, there's a lot more detail behind this slide, but this is just a snapshot of the pieces that we're looking at. Phil, you have a question, Philip, about mental health claims included in the total cost. And yes, we are looking at mental health as well as physical health in this. Okay.
Will we be receiving those claims?
Yes and no. So let me go through a few more slides and see if that answers your question.
Okay.
So next slide, where are we getting this data? Where is this data coming from? So we are collecting a new data submission from all of the payers and TPAs that have at least 1,000 covered lives in Oregon. So just like we notified all of you and said, you've been identified as a provider organization for this program, every year we reach out to all of the payers and say, you've been identified as a payer with this many covered lives, and you are a mandatory data submitter. That data submission, we have a data submission manual and a template. I'll share the link later. You're welcome to dig into that and take a look at what we're asking the payers to do. But that includes both the claims and the non-claims-based payments that are being made to provider organizations. We've gone through the validation of our initial data submission, and we just finished that up with 32 payers. So we are collecting data from a lot of different organizations. The payers are tracking which dollars in which categories and to which providers. And let's talk about how they do that next. So all of the data reported in this data submission at the provider organization level is based on a payer attribution. And it's a hierarchical attribution that we've asked payers to do based on one of these 3 options. So if a payer has a member selection or a member choice component, so an individual gets to choose their primary care home or they get to opt into their PCPCH, that is the first tier of attribution, and that is where that patient is attributed to that provider. The second tier of attribution is contract arrangement. So if there is a contract where the provider organization is responsible for certain members, those members are attributed in that way. And then third, there's a utilization-based algorithm. So based on a payer's methodology of how they attribute based on utilization. And there are a whole bunch of different ways to do that. And it varies by payer how they do that. There are also unattributed lives. So there are plenty of individuals that the payers were not able to attribute to a provider organization based on any one of these 3 options. Those patients, those members, their costs are reported in an unattributed category, and those costs are not attributed to any of the provider organizations. So provider organizations would only be seeing attributed costs for attributed lives based on one of these 3 options. Next. The spending follows the person. So for an individual that has been attributed by a payer to a provider organization using one of those three options on the last slide, all of their healthcare spending is attributed to that provider organization, whether or not it was delivered by that organization. So there will be some spending that the provider organization directly provided, probably. There will be some spending that follows that person that that provider organization did not provide, but that is attributed to them. So to the question of will you see the claims or not, yes and no. If you are the provider organization that provided those services, then yes, you should be seeing that. But you will not necessarily have been the provider of all of the services that are being attributed because the spending follows the person. And that comes back to why we're talking about total medical expenditures and that total cost of care approach. There is risk adjustment as part of this data. So for the initial data submission, payers applied their own risk stratification, their own risk adjustment methodology to the data. We've been working with the payers on shifting from risk adjustment to an age sex adjustment, and that's what we'll be using going forward. So there is some adjustment that is baked into this data, and that is all applied. And again, there's a lot more detail on this in the data submission template and manual that we can share if people want to take a look at that. We are starting to run out of time, so I want to jump to what is going to come next. Let's go ahead a couple more slides, Johnny. One more. Okay, so what we are doing is taking all of that payer data that we've received. We are then aggregating it across all of the different payer data files to say, here's what we see. Here are all of the attributed dollars, attributed lives for a provider organization. We are then going to have some data output, and we would like to bring that to you for those individual meetings that I referenced in my intro email. And we want to say, here's what we see. Here's what the payers are seeing. Here are the attributed lives. Here are the dollars. Here are the trends. Here are the cost drivers. And we want to validate that with you. We know from the other states that are a little further ahead of us that this conversation can be really tricky because we're talking about services that you didn't necessarily provide. We're talking about patients that may have been attributed to you based on contracts that you might never have seen in a given year. So there is some triangulation between the payers and you all to understand what's in the data and how we got that and how that all makes sense. But that is the next step of the process that we are hoping to kick off this summer in those individual meetings. We want to bring you that data. We want to have the conversation, talk more about what that is and what that looks like. We are treating these summer conversations, this first round of conversations with you, as a dry run. We will not be publicly reporting at the payer or provider organization level any of this 2018, 19, and 20 data. This will just be internal for your reference, for our reference, and to test out the process. We want to make sure that we have the right contacts, that we've gone through this and had a practice run before we get into next year's cycle where there will be public reporting. So we really hope that you are able to engage with us and have these initial meetings. We'll have lots more time to talk about how the program works, to talk about the different data that we're providing, to understand what the data that you have in-house looks like. We expect that there will be some differences. You might say, look, we have a total cost of care contract with this same payer. Here's what their report says. Why is that different? And we'll want to understand those differences and reconcile them to the extent possible. Okay, I am going to stop there. There is some more information in the slides about how to stay engaged, as well as some links to some more references. And as I said, we will send the slides out and post them online this afternoon or tomorrow. But let me see if there are a couple more questions in the chat. Detailed description of all the calculations. So the best place for detailed descriptions of the calculations will be looking at the data submission template and manual that we are asking the payers to use. That provides a lot more detail about how everything is, how the payers are preparing the data, and then will be the data that we'll be bringing to you as provider organizations for those conversations. In terms of future conversations and accountability, for these individual meetings that we're going to be reaching out to start scheduling with you, we are not asking you to come to these meetings prepared with a whole bunch of data necessarily. We expect these conversations will be iterative. There's no sort of checklist that you can pull to prepare. Certainly, there's some things we can suggest that you look at. We can ask some questions, but we don't expect that you'll come into that meeting, with a full set of documentation. Like I said, we want to treat this as a test run. So we will be having some conversations that say, if this was a year in which accountability mechanisms applied, here's what that would look like. Here's the questions we would ask you. Here's the kind of documentation we might ask you to provide, or the kind of supports or follow-up that we might ask you about in terms of understanding your cost growth and the reasonableness of it. But again, because accountability does not yet apply, this is a non-binding practice conversation. We do hope to share the data in advance of the meetings. We will, once they're scheduled, we will likely send an agenda, the data, and some structure for the conversation so that we approach this in a similar way with you all. We also know that, again, not all of you have been as in the weeds with this as you might want to be. And so we want to make sure that the data that we're providing comes with context and isn't super confusing. And we don't want to have you spin your wheels a whole bunch if there's some easy questions or context that our team can provide before we review that data together. Eric, you have a question about types of penalties. So the only penalties, we have the performance improvement plans, and then we have financial penalties. So that would be a financial fee assessed against an organization. And we don't have more details yet on how that would be calculated or what that would look like. That is work that will be coming up in the next year to develop.
Oh, I was just going to say, there was a question earlier on about has the pediatric population been included in the target? And
yes, pediatric populations are included in the target. And as we're moving to that age sex adjustment, there are adjustments by different age bands that will address including the pediatric population. And Kristen asking about cost growth target requirements are applied by market. So we are looking statewide by market, and we are looking insurer by market. At the provider level, we want to start those conversations by looking at cost growth in aggregate. Across all of your payers, let's see what cost growth looks like and what's happening, and then we will look more specifically by market. Where this applies most specifically is if a provider organization only meets that threshold for inclusion in a specific market, then that's the only market that we would be talking about. So if you only have sufficient member months in your commercial patient population, then we'll only be talking about your commercial cost growth. We would not be looking at any other markets. Okay, Jorandi, can you put up the very last slide with our email address real quick? I want to encourage people, please feel free to reach back out with any questions. Again, we covered an awful lot today, and I'm sure there are questions we didn't get to. We will start reaching out. You'll be getting emails from me, from Trang, or from Jorandi to request those individual meetings and to start getting those on the calendar this summer. Keep going, the very last slide. Yep. You can email us at any time. Our email is healthcare.costtarget@thsoha.state.or.us. Our webpage is here, and we'll be sending the link out. There is a lot of information on our website, including the recommendations report, the manual with all of the technical details for the data submitters. We will be adding a new for provider organizations section of the website, hopefully this week. That's where the slides and recording will be posted. We'll also work on an FAQ that will be posted, as well as more documents in the future as we begin more of these conversations with you. All right, I am done. Thank you all so much for joining us today. We really appreciate your time. Please feel free to reach out if you have more questions, and we will be in touch to schedule those one-on-one meetings shortly. Thanks so much.
All right, thanks everyone. Bye.